Hello everyone. In this class, we'll try to understand what is ventilation-perfusion ratio. There are regions in the lung where ventilation and blood flow are not properly matched. Due to this physiological mismatching, a small fraction of cardiac output is not normally fully oxygenated. The matching of airflow to the blood flow is studied by examining ventilation-perfusion ratio. The normal ventilation perfusion, that is VAQ ratio, is zero point 0.8. In upright position or posture, the base of the lung is better ventilated and better perfused than apex. Moreover, blood flow is proportionately greater than ventilation at the base, and ventilation is proportionately greater than blood flow at the apex. In fact, blood flow exhibits about five-fold difference in between apex and base of the lung, whereas ventilation exhibits about two-fold difference. This variation in the differences in ventilation and blood flow results in regional difference, that is VAQ ratio, that is ventilation perfusion ratio. The VAQ ratio is zero point 0.6 at the base and about 3.6 at the apex of the lungs. Okay. So in this diagram, you can see that the perfusion, both perfusion and ventilation, they are high at the base and low at the apex. Okay. Whereas perfusion from base to apex, it decreases by 5 times, and ventilation from base to apex, it decreases by uh, 2 times, that it becomes half the original. If you see the VAQ ratio at the base, it is zero point 0.6, and at the apex it is 3.6. That is, ventilation perfusion ratio is high at the apex and it is less at the base. Importance of VAQ ratio. The ventilation perfusion ratio is important for gas exchange in the lungs. At the apex, VAQ ratio is high because there is more ventilation relative to blood flow. Therefore, alveolar oxygen tension is high and carbon dioxide tension is low at the apex of the lungs. At the base, the ratio is low as there is more perfusion relative to ventilation. Thus, some amount of blood circulates through the base of the lung without becoming fully oxygenated. Clinical importance. Due to the difference in the regional VAQ ratios, some diseases are more localized to the part of the lungs. For example, tuberculosis occurs more commonly in the apex because favorable environment for Mycobacterium tuberculosis. The higher oxygen level facilitates growth of tubercular bacilli. So when there is a decreased VAQ ratio, uh, when ventilation to an alveolus is reduced relative to its perfusion, VAQ ratio becomes less. In this situation, due to the delivery of less oxygen, alveolar PO2 falls, and due to the removal of less carbon dioxide, PCO2 rises. Then, when perfusion is reduced related to ventilation, VAQ ratio increases, in which alveolar PCO2 falls due to the less carbon dioxide delivered into the alveoli from the blood, and PO2 increases as less oxygen is transferred from alveoli into the blood. So this diagram shows uh, decreased ventilation perfusion ratio and increased uh, ventilation perfusion ratio. Okay. So decreased ventilation perfusion ratio occurs when there is obstruction uh, in the lung, and increased ventilation perfusion ratio occurs when there is obstruction in the perfusion. Venous admixture and physiological shunt. Like physiological dead space that causes wasted ventilation, there is wasted perfusion. Wasted perfusion refers to the quantity of venous blood which is not fully oxygenated. The mixing of unoxygenated blood with oxygenated blood is known as venous admixture. Venous admixture occurs either due to the shunt or to a low ventilation perfusion ratio. Shunt is nothing but it's a channel in which blood bypasses the lungs. There are two types of shunts. One is anatomical shunt and physiological shunt. In anatomical shunt, blood bypasses the lungs through an anatomical defect. For example, in right to left shunt, admixture of blood occurs through the atrial or ventricular septal defect, as it occurs in ASD or VSD, or atrial or ventricular septal defects. This also occurs from a branch of the pulmonary artery connecting directly to the pulmonary vein. Whereas physiological shunt is in bronchial circulation, the deoxygenated bronchial venous blood drains directly into the oxygenated blood of pulmonary veins. So that accounts for physiological shunt. Normally, there is a physiological dead space as well as physiological shunt in the lungs. Low ventilation perfusion ratio. This occurs when a fraction of pulmonary capillary blood is not oxygenated due to the low alveolar ventilation. Normally, this occurs at the base of the lung. So, this can also occur if an airway is partially obstructed, that causes hypoventilation. The fraction of blood that passes through the hypoventilated part of the lung is not fully oxygenated. So, this results in venous admixture. Coming to the bronchial circulation, the bronchial circulation is the circulation that supplies the blood to the walls of conducting airways and surrounding tissue. Bronchial circulation perfuses the upper respiratory tract. It does not supply the respiratory bronchiole or alveoli. The venous return from bronchial circulation is either by bronchial veins or by bronchopulmonary veins. Bronchial circulation receives only 1% of the cardiac output. However, in some inflammatory disorders of airways, such as chronic bronchitis, it can be increased to 10% of the cardiac output. Bronchial arterial pressure is almost the same as that of aortic pressure, and the bronchial vascular resistance is much higher than the resistance in the pulmonary circulation. Physiological importance is the bronchial circulation, uh, don't confuse with pulmonary circulation, is capable of undergoing angiogenesis, that is the formation of the new blood vessels. This is very crucial to provide collaterals to the lung parenchyma when pulmonary circulation is compromised. When pulmonary blood flow is obstructed by a clot or embolus, the lung parenchyma supplied by these vessels uh, survives due to the perfusion by newly formed blood vessels. So this is in brief about ventilation perfusion ratio. Thank you.